Fantastic. Hello, good morning, and welcome to our January edition of Implant Threads. Today we are very humbled to have Dr. Salah Arya to discuss the use of lasers in implant dentistry. Salah has qualified back in 1999 in Stockholm and then moved over to the UK, where he bought his first practice in Hornchurch in Essex, where he's grown it from a single-handed practice into a very substantial multidisciplinary place to work. He specializes in implant placement and does some cosmetic dentistry and Invisalign as well, and has a keen interest in the use of lasers in the placement of implants. So should be a really good lecture. Really looking forward to this. If anybody has any questions, please pop them in the chat and we'll get to them at the end, and we'll take it from there. So over to you, Dr. Arya.
Thank you, John. Thanks for a kind introduction. Of course, this is a webinar for VSSAcademy. So I'm sure you know the VSSAcademy leading platform for dental education, empowering professionals through the high quality, hands-on training and cutting edge learning. So of course, they have got the interactive monthly series bringing the implant community together. They share real-world clinical cases, they debate treatments, and they learn and move on with better treatments. So when we're talking about enhancing implant success, so we would like to understand how we can do the implant success quite rightly, and maybe in this case, as mentioned, lasers as well. This is my practice in a suburb of London, Hornchurch, Harrow Dental practice with their own academy as well. And yeah, as John mentioned, from 1 month practice expanded to 10 months practice. So we are quite a busy practice, and I love to work with them. See them more than I see my family, which is that is the downside sometimes. So my screen, yeah. So as Albert Einstein said once, the world we live in today has got a problem which cannot be solved with the same thinking we thought them, we created them. What that means for us? That means for us, progress, innovation, and solution cannot be done with the same way thinking we done yesterday. We do need a new way of thinking. It is exactly for us. Either is in dentistry, either is in education, surgery, normal dentistry, general dentistry, implantology, oral surgery, whatever you're thinking, we do need a new way of thinking. Today we live in AI era. If our patient can go to ChatGPT, they can ask what treatment I should have, and they get full amount of the information, what sort of the treatment they do need, and they can get it. Of course, one of them might come out a laser as well, which it does. When talking patient minimally invasive, straight away they are coming up with the AI game laser as well. So biology is biology, but how can we help the time go faster? Basically, at the end of the day, our patients coming to us asking treatment. They don't ask pain. They don't ask trouble, complications. How we can get the healing faster, less traumatics, and successful treatment. That's what our patient looking for. So implantology is implantology, right? What is the main problem in implantology? I'm sure you know the main problem is a lack of the bone. If we have got the bone, we easily be able to place implant. And of course, soft tissue is another important part. Prosthetically driven positioned implants, another part. But if we haven't got the bone, we do need to get the bone grow. For that, of course, if we have got the problem, we can do GPR, right? Lack of the bone, we can do GPR, which we learned over the years. How invasive is it, this GPR? With my computer. And we do block graft, particulated bone graft. How is the morbidity of that one? We do alloplast, all sorts of the, and then how long is going to take this major surgeries? Bone expansion. How predictable is that? So we learn all these major surgeries. We do sinus grafting, we do block grafting, we do core technique, we do splitting, everything what you can do, we do mini sausage, all this we doing. But can we avoid all this or cut down the minimum? We've taken out the tooth. And what we're doing, we have got lack of bone. We might put some xenograft in, and xenograft there, after years, we open the steel xenograft. And we might do some temporary denture over there. But when we come into restoring that one, do we get the exactly same neighboring tooth anatomy there, neighboring tooth good looking there? Might be not. Look at this case. In the bottom, we can see that after still soft tissue in not good condition. Yes, our colleagues or some of us, including myself, we can do different treatment. We can get the bone augmentation, soft tissue grafting, but how long is it going to take? How long the patient need to wait for this? As a Latin and says, first do not harm. In the first place, we should take care of the anatomy. We should take care of the nice convexity around the tissue we have got before we losing all the resorption, all the bone and soft tissue. From a traumatic extraction to soft tissue sculpting, from infected socket to complex cases, lasers are redefine how we approach oral surgery and implantology. When I first integrated laser into my surgical and implant practice, I realized it was not just the new tools. It was, and still is, a new way of thinking about patient care, tissue preservation, and long-term results. With great success and less pain, quickly and more success. Someone could ask why we need to rethink oral surgery and implantology. My friends, every day we're facing the same dilemma as a dentist. How we can achieve precise, how we can cut precisely, how we can preserve the tissue, how we can reduce the trauma, and still meet the patient's high expectations, which are aesthetic and comfort. With the laser, we do not change our instrumentations. We just transform our possibilities. Last 2 decades study has shown us the dentistry, the surgery has moved from pure mechanical method to more biological driven. Lasers not only cut the hard and soft tissue, they also contaminate infected socket and disrupt the bacterial and making this microablation make available us let us cut the both and hard soft tissue some simultaneously we coagulate in those small blood vessels when we cut in, so we have got a better surgical field view. When we cut him with the scalpel, we have got a huge amount of the bleeding. What bleeding means, as we cut him with the as we cut him with the scalpel, immediately we create an inflammation. Inflammation means what? Inflammation means pain, swelling. But when we cut him with the laser, those small blood vessels coagulate immediately. That means the inflammation stops. That means that we have got better surgical view, surgical field, so we can see what we're doing, rather than we try and keep cleanest possible with the big suctions and then still we cannot see what we're doing. But when we cut them with the laser, we will be easily see what we're doing. So let's look at this case, for example. We have got the big odontoma here, right? What is the problem with odontoma there? Patient having orthodontic treatment. There we have got odontoma close to nerve canal, the same time close to adjacent teeth. If we go and cut with the conventional way, we might damage the nerve, we might damage the adjacent teeth. But when we cut in with the laser, so we gently removing the bone and accessing the odontoma, and we can remove without causing any problems. So I talked about try preserve. What about talk about immediate implant placement? Why we place an implant in the first place? We do place implant when we can't save the tooth. That tooth might be infected periodontally or even endodontically failed tooth. That we have got the bacteria for caries. Those the bacteria that are difficult to get rid of. But when we use in the immediate implant placement, we have to think about it, how the socket healing biology is going to happen. What is the case planning? We have to plan the cases. And then, of course, how we go and proceed. So timing for implant placement is important as well. If we do in the same day implant placement, if we have got enough bacal bone, and then we can place implant, of course, without no problem. But if we're not doing that, we might end up losing so much bone and the soft tissue, which later on, yes, we can place implant, but we do need a major bone augmentation if we look at the right-hand side book. So study showing us, so that after 50% approximate resorption happens after 3 months. So if we can get this implant being placed as soon as possible, then we losing less bone, which I will come to in a minute. So after 2 months, what we end up, we losing so much bone, so we can prevent this with remodeling with an implant. Can we do that? Let's look at the case. Immediate implant placement. Same socket healing biology. We extracting the tooth atraumatically, we place in the implant, we doing the soft tissue grafting simultaneously, and filling the gap junction between the implant, and immediately we can restore it. Case planning is important for the immediate implant placement. Do we have got enough bacal bone? Do we have got the anchorage? That is important. What performs immediate implant placement is important. Type A bone, we can immediately place implant, which is favorable after anterior maxilla. Of course, nowadays I do place implant in the molar as well immediately. There is a technique to do it, and I'm sure a lot of you guys know to do that. What about margin? What about soft tissue? Soft tissue is an important part as well. If we are according ITI guidelines, if we have got absence of recessions, of course, it's much easier. But when we have got minor recession, amber sign. When we have got the major recession, that is a red flag. So we should be careful while we try and achieve it. Aesthetic analysis is important as well. Patient might haven't got that aesthetic, but as soon they start in spending some money with us, they still looking for the perfect smile, even if hasn't got all other teeth in perfect position. So there we do need to talk to our patients, what we need to achieve, what they would like to achieve. Soft tissue quality is important. Again, ITI guideline telling us thick gingiva phenotype is favorable. But when we have got thin phenotype, there is a limited keratinized gingiva. So there is an amber sign. Absence of the keratinized tissue is a no-go. So we have to deal with the soft tissue as well before we do anything. Assess of the gingiva phenotype. So easily, I don't need to teach you guys, you know how you can assess the gingiva. So if, of course, if it's a probe shining through, so you have got very thin phenotype. What about bone anchorage? Have we got enough bone? Can we place implant immediate loaded? If we have got sufficient bone anchorage, of course we can place implant and immediate load possibly. But when we have got limited, still we can place implant might be immediate load, but has to be a bit experience of that. But we haven't got lack of the bone, so of course that is going to be difficult case again. What about facial bone? Study showing us often the patient is between 0.79 mil bacal bone, less than 1 millimeter bone, most of the patients. Of course, those patients going to be difficult. So if we extract in the tooth, we place an implant, so we have to be more experienced. That bone is a bundle bone is going to absorb away. So we cannot place implant immediately like that, unless we know what we're doing. So bacal bone is important. What about infection? Of course, when we have got the infection, that makes it more difficult. We have to be able to clean that infection. What instruments, what chemicals, how we going to get rid of? Do we need to extract the tooth first, leave for late, immediate placement? That's what we have to take care of that as well. So when we have got the alveolar defect and the infection, might be the ITI guidelines telling us, so no go. Deal with the issue first before you place an implant. Bacal socket. So of course we have to, we've been told always, and we know that 2 millimeter bone, we need our bacal bone or supported implant and the soft tissue as well. Less than 2 millimeter is going to be issue for us. We do need augment. So again, so we know how we can place the implant. If we extract in the tooth and placing immediately implant this apex, the same socket, of course, implants going to tilt buccally, and then we haven't got enough space. And those bundle bone is going to absorb away immediately in a few weeks. So therefore, we do need to get the buccal, of course, prosthetically driven position, but at the same time, native bone of the apex, or as much as possible to palatal bone position, the same time prosthetically driven. Please don't forget, prosthetically driven position has to be it. Buccal-palatal, again, the same. So we have to have a thickness of the bone, so to be able to place our implant prosthetically driven position. So the risk assessments ITI guideline tell us if it's green, so we are go, and the yellow is the amber, and the red is, of course, is a red flag sign. So we have to take care of that as well. When we're talking about immediate implant placement, immediate loading, fabrication of our immediate implant, immediate loading is very important. If we haven't got the concavity and we place in, our technician might be sometimes giving the best crown you can, but glazing below the tissue, below the margin of the soft tissue, that soft tissue is not going to attach there. So we have to make sure our technician not glazing the above the abutment. In this case, can be used as zirconia, of course, but shouldn't be glazed at all. Above the margin of the soft tissue, yes, glazed nicely. So timing of implant loading is important as well. Type A, we can do same day or week. When we have got the early placement, can be type B and type C, which is after 8 weeks or so. We shouldn't restore immediately if we haven't got the type C bone. And clinical procedures, as I mentioned, if we extract in the tooth, we place an implant directly to apex of the tooth. That implant's going tilted to buccally as tilt, and then we haven't got enough bone there, and the bundle bone is going to absorb. So we should get, as in the picture I'm showing, so we should get to the as much as possible to palatary position, same time prosthetically deviant position. And of course, junction has to be built up with the bone and soft tissue. Again, risk assessments, which you guide ITI guideline. In vivo studies showing us healing process often occur in jaw rabbits following a perforation by erbium chromium VSGG laser. What the conclusion was, erbium lasers allow us a precise and surgical ablation with minimal thermal damage to adjacent tissue. That is the important part. So we're not damaging the tissue. We just cleaning, we just minimally invasively doing our surgeries. Again, study showing us that the complete bridging of the bone defects by Metron laminar bone was finished by after 70 hours. So again, laser, I don't want to bore you with the studies, but what I'm just trying get here, the use of laser prepare the implant site without debris formation. Imagine we place an implant, we drilled our bed, we prepared our bed. After then what? We create a smear layer. We know the study showing us this smear layer will take 6 weeks body to get rid of. Imagine you have got the implant bed and implant itself. Microscopically, we have got the smear layer between implant and the buccal bone or implant bed. Those smear layer will take about 6 weeks to get rid of them. If we could think out of the box, we just clean in with the laser those smear layer before we place an implant. So now we have got 100% contact with bone and the implant surface. Therefore, we accelerate in the healing. Therefore, we accelerate in the loading as well. Post-extraction implant, has become common practical. Nowadays, almost everyone places an implant immediately. Incidence after complications such as infected post-extraction, laser can significantly reduce the bacterial contamination after extraction and with compromised tooth, which I mentioned. Immediate implant placement, and what is the advantage? Advantage is facilitate maintained horizontal and vertical dimension of the osseous and reduce the trauma, enhance the patient comfort, and good aesthetic results. What disadvantages of the immediate implant placement? Certain local systemic factor, which is a contraindicated placement of the immediate implant placement. The presence of bacterial infection, which we know that after we take it off the tooth, because infected tooth or fractured, or we can't save the tooth. How we can do that, prevent them, is a flapless technique. We might use it. Use of the bone graft and use of the connective tissue. So if we look in that, so study showing us as well. So if we have got the 1 millimeter buccal bone, gap junction has to be built up. That is important. So the same time study showing us, we do need to do soft tissue grafting as well, support that bone and the buccal bundle bone. What is the conventional? So found that the reason for extraction could affect the survival rates of immediate implant placement. So often endoperiodontal disease failed significantly more than site periodontal disease only. The study showing us. So that when we have got the endoperio lesions, that has got the bacteria, which is more difficult to get rid of. But with the laser, we can do that, which I will show you the cases. With the conventional way, we mechanically debridement, potentially placement of the immediate medication or dressing, and promote healing and disinfection. When we're using laser, energy used to kill the bacteria, remove the tissue, and promote the healing. With the laser, which water laser in this case, I'm talking about, when we use in water, so we get in OH, which is a radical for very toxic for the bacteria, basically clean the membrane of the bacteria. So therefore we can get rid of the bacteria. So what is the action? Mechanical action, mechanism action. Conventional extraction socket debridement. When we use in the burr or any instruments, even we not removing the infected tissue, but at the same time we removing healthy tissue as well. But when we use a laser, can affect including microbial killing and then coagulation, sealing blood vessels, and the tissue stimulated from healing, which is a photobiomodulation. When we're talking about precise and selectivity, of course, when we use a drill, we cleaning with drilling out healthy tissue, as I mentioned. But when we use a laser, we selectively removing what we need removed. So, of course, pain and discomfort. When we using conventionally with all rotary instruments we use and all the cleaning, of course, we're creating a bit of pain and the swelling and bruising. But when we're using laser, generally associated with less pain, discomfort, and operative recovery, faster healing, reduce the risk for complication, and has got the bactericidal effect as well. So, my friends, knowledge is power. So if we know where we're going, so we can find what we need to find. Let's look at the infected tooth, for example, there, minimally invasively. I'm using laser as a periotome. I'm just removing very gently the tooth, and then we can do that. Let's look at this case. What's the problem with this case? Failed the tooth. And we have got the fistula. Can we place implant immediately? In some cases, why not? But in this case, I'm doing that. After using the laser, removing all the granulated tissue away and infecting the socket, and then we're removing the tooth. Now it's time, which I'm not going for the parameters. In this case, you don't need the parameter. So I'm removing all the granulated tissue away, very minimally invasively. And there's the granulated tissue I'm taking away. So then place an implant. Now it's time to repair that damaged soft tissue. Before I'm harvesting the pregingival graft, I'm de-epithelializing the soft tissue pregingival, and then harvesting the soft tissue given to recipient side. After soft tissue being secured to recipient side, and now it's time to augment. And then do the choice of your material, augmenting the side. And in this case, I'm using anatomical healing abutment to be able to protect the soft tissue, protect the bone, and protect the anatomical structure. And there's the emergence profile 3 months later. So what I've done here, I haven't lose the papilla at all, which in this case, when we extracting the tooth, we normally lose in the papilla. And we lose in the bacar bone recession, of course. So then later on, patient has got difficulty with all the cave under the crown or papilla, or so it's a bit difficult, and often has got the TP brush with them when they go into restaurant or the meal. So from there, we get into there. Let's look at this case. Decontaminate extraction socket. After then, I'm harvesting the soft tissue from the, in this case, I do use the tuberosity, and then placing the soft tissue to recipient side and chair side immediate loading and final restoration. What about this one? We haven't got the buccal bone and very thin phenotype soft tissue. Or in this case, what I'm doing after I using laser as a periotome, extracting the tooth and decontaminating, removing all the granulated tissue away. Then placing, of course, bone. That's the what I mean in here, but you can see that I'm not using the apex of the tooth as the point of the placing implant. Implant has to be, if we go immediate loading, in the palatally position as much as possible, and then native bone. After taking the soft tissue, in this case, you can see here, I'm harvesting the deepitalizing free gingival graft, and I'm harvesting the free gingival graft and placing to the recipient side. But what important part is I haven't done any placing any collagen on the palate or any composite or any guide, whatever. What I'm doing in this case, I'm just laser bandage, basically coagulating the palate without and even let heal in 10 days will be healed very nicely. After soft tissue placed and the bone augmentation and immediate loading in this case. And that is the final restoration. 2 months follow-up, 2 years follow-up, and then we can see nice healed case. What about this case? We have got to fracture the root of centrals and the young, I think 25, 26 years old. That has to be removed. But if we retain the root, if you can appreciate the retained root, very thin bone, and in this case, if I'm going to remove that retained root, what will going to happen? I'm going to lose all the buccal bone, possibly palatal bone as well. In this case, what I'm doing with the laser help, I'm extracting off the tooth, and then I'm doing like a socket shield technique. Basically drilling the and getting nicely whole to or nicely bed for my implant. Of course, after you're done, you have to do your final drill, get the nice shape of the final drill of your implant, choice of implant, to be able to place a nicely implant, and then decontaminating the smear layer out before I'm placing implant, as I mentioned. Implant being placed and the primary stability checked. I've got the 73, which is quite reasonable to immediate load. In this case, I'm harvesting, again, deepitalizing the soft tissue from the palate, free gingival graft, and then harvesting the soft tissue and giving to recipient side. And I'm using patient's own tooth, which is what fractured root, as the immediate load, as a temporary restoration. So this is the 7 days after. You can appreciate the palate healing very nicely. And I haven't used anything else, just the laser bandage, just the coagulated the bleeding and the let heal. If it's still some bleeding, sometimes I do use a couple of drops of surgical glue to just coagulate it, let the heal back. Three months later, I've got very nice emergence profile. So then now it's easy to restore and follow up the case. This is a final restoration, pre-op and post-op, and follow-up. What about this case? 78 years old gentleman just walked in. In this case, what are our patient looking for? Are they looking for pure cosmetic, or are they looking for function? Of course, 78 years old, probably looking for more function rather than cosmetic. Yes, we can see that cosmetically, overall, the place is not a golden proportion there. But that is not the case. What we have to be minimally invasive for our grandfather to be able to give the restoration he deserved. In this case, I'm using laser after removing all the granulated tissue. Please appreciate how much granulated tissue nicely coming out before I'm extracting the. Can you see all the tissue coming out? Before I'm extracting the tooth. At the same time, I'm using laser as a periotome. The tooth being extracted. And now it's time to clean all the infected socket out, infected tissue out from the socket, and then place the implant. Again, go back to palate, deepithelize the soft tissue, pregingival graft, and harvest after deepithelizing, which is much easier to deepithelize rather than outside on the piece of wood or tissue or glass, which is often a bit difficult. Given to recipient side the tissue and securing to the recipient side, of course. And now it's time to augment. In this case, I'm using a PRF as well to secure more sealed temporary restoration. What we see sticks out there is a PRF. That is not the soft tissue. It's a PRF, just sealing nicely the socket. And there is a 3 months later emergence profile. And there is a restoration. What about this case? Let's spend a minute or so in this case. What we have got here, infected tooth, of course, loose, and the nerves exposed. We can see floor of the nerve is exposed. And patient coming to me with tingling the lip, numbness basically. Of course, in this case, I've used the direct laser for photobiomodulation to be able get the feeling back to patient after a few sessions. Of course, I did get the patients feel normally. But extracting the tooth, now we do need to clean all the infected granulated tissue out. But please mind, if we using any instruments, any hardware, we might create more damage which already exposed the nerve. So in this case, I'm using laser very minimally invasively, remove all the granulated tissue out. Without harming or damaging any other surrounding very delicate anatomical structure. That is so now we have got very nice clean. In this case, I'm using allograft for bone augmentation. I prefer to take a patient's own from retromolar, but the patient didn't allow me to go to opposing sides. So in this case, I haven't chosen to go to allograft. So harvesting autogenous graft and placing secure into the site. When it comes to placing implants after 3 months later, so I always use a very thin layer of the xenograft to be able to keep the volume up. As we know, the autogenous graft might absorb some of them. So therefore, I always use a xenograft, just the thin layer to be able to keep the volume up. After implant placed, of course, the next step is going to be the soft tissue grafting, which happens later. From that, which we hadn't any bone at all, and we had damaged nerve almost. We augmenting and placing. Thanks for the laser, I could minimally invasively to be able to clean and place implant, augment. But can we save all the implants sometimes? Possibly not. In this case, we can see the failed implants, failed soft tissue, and even upper lateral, right lateral is mobile, heavily decayed and mobile grade 3. In this case, I'm using extraction, explanting the implants. After extracted the implants, now it's time to clean all the infected socket out. All the infected sockets being cleaned. We can see appreciate very nice cleaned surface. Now we can immediate implant placement, even we explanted the implant. Harvesting autogenous bone, mixing with, in this case, allograft, and placing implant, augmenting the site. And of course, in this case, I'm using mini sausage technique to be able to cover, stabilize the bone. So 3 months later, what's the problem now? The problem, we have got the very shallow sulcus there, right? Vestibulum. What we do in this case, as experienced surgeons you are, all of you, and of course we have to do grafting, in this case, pre-gingival graft. Rather than I'm doing pre-gingival graft, I'm going different technique. What I'm doing, I'm just doing basically frenectomy, releasing the vestibulum. There we have got released the vestibulum. You can see a few places small bleeding. I'm just there's not a carbonization. There is just a laser bandage coagulating the bleeding. At the same time, I'm exposed the implant to be able to scan for my immediate temporary restoration to be done. When it's a temporary comes a week later, so I'm placing the temporary, and 6 weeks later we have got very nice keratinized tissue around it. And I haven't done any pre-gingival graft, just to release the tension, let the secondary healing, minimally invasively, rather than going to harvesting pre-gingival graft. And again, pre-gingival graft to place in there, how successful is that? Yes, can be very successful. I have done many of them, so I know it can be successful. But I've got the colleagues which are calling me back, say, "Oh my God, failed. What I'm doing now." It can be tricky if we don't know what we're doing. But releasing the just the tension, letting the secondary healing made it easy, just the restoring there, and there is a final restoration. So thank you for your attention. If you have got any questions, please fire away.
Fantastic. Thank you very much for that, Salah. That was really interesting. It's the first time I've actually sat in a lecture where we've discussed lasers, and I think I can see the huge benefits, especially for sort of soft tissue sort of manipulation,
Yes.
but also for degranulation of sockets. That's fantastic. I've got a couple of questions. So if anybody has any questions, please pop them in the chat. Don't make it just all about me. So I'm assuming that you can use lasers on any sort of type of bone density from like D1 to D4.
Yes, you
Does
can.
does it handle differently?
No, the how the laser does work. Laser basically, if you're using for soft tissue with contact mode,
Hmm.
and then hard tissue non-contact mode. Why non-contact mode? Because when we ablate in the bone or enamel or dentin, wherever we're going to use a hard tissue, so if we contact mode, all the debris flying to blocking the edge of the tip or damaging the tip. But when we're using 1 millimeter away from the bone, or in this case, hard tissue, so all the water and the air spray basically washing away the debris from the which come in that damaging the tissue. And then parameters is important. Understanding, as our professor unfortunately passed away with the COVID, the professor Norbert Gutman, and he used to tell us we shouldn't be button pusher. We should understand how the laser works first. So if you am going to use a laser for bone, for example, there probably I will use a 6 watt.
Okay.
If I'm going to clean the decontaminate, probably I will use a 3 watts. Repetition rate is important as well. For soft tissue, if we're using repetition rate, say is 50, 75 hertz, that will be very nice smooth cut. Of course, we can cut with the 75 hertz bone as well, but will take ages.
Okay.
But we use 15 hertz, 20 hertz max. So that will be easy cut. I do harvest the from retromolar area a block to with the laser, minimally invasively. So and then I of course harvest and give to recipient site where I need it. The important part is that we understand how the laser does work, what the penetration there, what tip we have to use, what parameter we have to use. Yes, we can cut the hard tissue as well.
Hmm. And do you find that you get with different wavelengths, do you get different heat generation with it as well?
Yes, if you're using a CO2 laser, for example, of course, you go and get the carbonized
Hmm.
tissue. But if you're using an erbium laser, which is the erbium YAC 2940 nanometer, and or erbium YSGG, erbium chromium YSG 2740 nanometer. So there is a different depth penetration as well. Erbium chromium YSGG laser penetrates 300 times deeper than erbium yak. That means so we can cut the same time we coagulate more.
Hmm.
With erbium yak, if you're using so some more bleeding, especially in the soft tissue, more bleeding. So it depends on which laser we do use. Heat generation, no, we're not getting any heat. Of
Okay.
course, we do heat it, but not because we have got the water and the air as a mist. So therefore, we're not getting any heat. Study showing us even using for doing the what's that pulpectomy or coagulating the pulp. So we're not increasing the temperature in the body at all,
Okay.
which is a if you have got the fever, so you go and have some temperature, right? Still
Yeah.
not damaging your teeth or your body or anything. So that will not increase more than 1 or 2 degrees.
Fine. Oh, that's interesting. A couple of our delegates have got some questions. What's your take on Nova Matrix instead of doing a CTG or a free gingival graft?
I have used the Novamac, of course. The Novamac is a good material, but uh, problem with the Novamac, so we have to understand Novamac is a magnesium. Magnesium releasing a gas. Some of my patients mentioned there was a big pain. They didn't like it. And no, if Novamac exposed, Novamac will quickly absorb rather than the time we have got. So yes, you can use it. It's a bit sometimes difficult to handle if you don't know how to handle.
Mm.
But again, Novamac, yes, protecting the basically the what's the socket not collapsing, and you can augment, you can do the. But in my opinion, later on you do need soft tissue grafting as well.
Yeah. Okay. And with the sort of the last case that you showed with the vestibular correction, what sort of flap did you raise there, and did you
I
leave
didn't
the?
raise a flap. I just
No,
did like a frenectomy.
yeah.
You just
Um,
releasing the tension, letting. When we doing a free general growth, what we doing? We releasing the flap, right? We
mhm.
securing the mucosa on the bottom of the vestibulum there, and then either we can use a Eastman Urban's technique and like a band over them, let the heal, or we can do fully free gingival graft over them. And but the free gingival shouldn't touch the mucosa. We have to secure properly and no movement.
Okay.
In this case, I'm not doing all of them. I'm just releasing, letting the heal, secondary healing. So then we get in the nice vestibulum correction and keratinized tissue.
You leave the periosteum undisturbed?
Yes.
Yes. Okay. And the where would you get more in-depth training on the use of lasers if one's considering to introduce lasers to their own practice?
Of course, there's a lot of the courses going, and some courses I have myself as well, which we're going to come very soon. Is 2 3 days courses. One is a diode laser course, which is a soft tissue. Only you can do the soft tissue with the diode laser. Then is a erbium or a yak laser, water laser. So that is a hard tissue. Then we have got the intermediate courses as well, which is for advanced cases. The best is we have got the CTC courses, WCLI courses from YLAs, or now is a Megagen. So they run in the courses, so you can learn them. But the important part is to learn for a small amount of physics. Physics is a boring part, but is absolutely needed. And then safety. So that is the one part. And then, of course, we have got the mentoring as well. A lot of the places, some people do the mentoring. So I do normally lecture a lot internationally rather than nationally myself. So I always on a on a way. But yes, if it's an interest is there, so I can guide easily. When my own courses coming as well, so I will mention. But I do a lot of know a lot of the courses coming up, so I can mention them.
Sure. Fantastic.
Just drop a text or email or whatever, so I can send the details.
Fantastic. Thank you. Um, Richter's asked what lasers you would recommend, but I think you've already sort of gone through that. Um, Post-operative sort of pain, swelling, bleeding, that sort of thing, using lasers drastically reduced compared to sort of scalpel blades, you would agree?
Enormously,
Any other
enormously.
sort of post-op complications you would sort of advise patients of that sort of maybe different to sort of more conventional technique?
It's not so much a difference. I mean, let me just explain this one. I did publish a paper regarding impacted wisdom teeth. So then in this case, I did bilateral, the same patient, blind technique, blind basically. So I didn't see the measurements.
Hmm.
One of the girls was doing before I'm extracting the tooth, impacted wisdom tooth, lower basically, and measuring the mouth opening. Of course, I couldn't measure all other bruising, swelling, and the pain, but then would it be enormous 500 cases, which was a bit difficult to achieve that time. So what we did measure the only mouth opening. Or we doing the treatment, and then immediately after and a week later as well. One side conventionally, another side with laser totally. Those cases which we had conventionally, even after 2 weeks, they had a limited mouth opening. But with the laser, we did, with the laser that side, almost the day after as well, back to normality. Of course, stitches, you have got stitches pulling. So therefore, sometimes they said maybe stitches was more annoying than anything else. So with the swelling, bruising, bleeding reduces enormously. And of course, pain. Pain comes from inflammation. When we have got if you're cutting yourself with your finger, immediately you feel an inflamed tissue and you feel in pain.
Yeah, it's true. It's true. Fantastic. If there are any more questions, could you please pop them in the chat? That would be great. Just as a bit of a heads up for our next implant threads discussion, that will be on the 28th of February, 10 o'clock again, and it will be with Rob Dias, who will be talking all things implant complications and how to try and avoid them and how to get around them as well. So that'll be a good one for us next month. I will just wait. Last call for questions. And
So I didn't
I
do too many slides. So I want a
no, that's
discussion
fine.
more than just
Yeah.
I'm showing off the cases.
No. I really appreciate sort of being able to see your casework and watching the videos and the photographs. I think it's a really nice way of learning and showing sort of these techniques and how we can sort of implement them. It's much better than sort of showing studies and things like that, I find. But no, it's been really good. So I'll from on behalf of everybody at VSS and behalf of everybody at who's watching at home, I'd just like to thank you very much for your time this morning. It's been absolutely fantastic to have you on board and hope to
Thank
see you
you. The
again very
pleasure.
soon. And thank you for everybody for attending. And thank you to Alan, who's been lurking in the background as per usual. And we will see you all on the 28th of February, 10 o'clock with Rob Dias. So hope you all have a good day. Take care wherever you are. Bye for now.
Thank you.
Thank you. Thank you both. Thank you, everyone.
Thank you.